السلام عليكم يا جماعة، مساء الخير. طبعا احنا سعداء جدا النهارده بان احنا نفتتح الكورس التعليمي، كورس على الهيب. ذا هيب ستيت اوف ذا ارت، احدث حاجه موجوده في جراحه مفصل الفخذ. وفي البدايه بحب اشكر شركه انسباير فارما على السبورت والدعم المستمر لجمعيه جراحه العظام المصريه وللانشطه العلميه. شركه انسباير فارما الحقيقه من الشركات اللي ليها باع طويل في صناعه الدواء، ويسعدنا جدا وجودهم معاهم في جمعيه جراحه العظام المصريه. طبعا الكورس يتكون من 4 ويبينارز، كل واحد منهم ساعتين. كل يوم جمعه الساعه 9 مساء ان شاء الله، ابتداء من الجمعه دي. كل جمعه ان شاء الله هيبتدي موضوع معين من الهيب. النهارده الموضوع هيكون fractures of the proximal femur. يسعدني طبعا ويشرفني وجود الكوكبه العظيمه من الاساتذه اللي لهم باع طويل في هذا المجال، وعلى راسهم طبعا الاستاذ الدكتور علاء الزهيري، استاذ جراحه العظام بكليه طب قناه السويس ورئيس الجمعيه الاسبق، وطبعا من الرؤوس طبعا في مجال التثبيت الداخلي، كلنا عارفين هذا. والاستاذ الدكتور عصام الشريف طبعا استاذ جراحه العظام كل الطب جامعه اسيوط، طبعا هو غني عن التعريف دكتور عصام، والديليجيت للسيكو في الشرق الاوسط وافريقيا. الدكتور عصام الحقيقه لا يتاخر تماما عن المساهمه بانشطه الجمعيه بعلمه الغزير. والاستاذ الدكتور عبدالسلام عيد عميد كليه طب الزقازيق وامين عام الجمعيه في نفس الوقت طبعا. ان شاء الله برضو النهارده هيدينا محاضره قيمه جدا. البروجرام هيبتدي بالاستاذ دكتور علاء الزهيري، هيتكلم على الفراكشر نيك فيبر في الادلتس افتكر والجيرياتريكس. بعد كده الدكتور عصام الشريف هيتكلم على السبتروكانتريك فراكشرز. بعد كده الاستاذ الدكتور عبد السلام عيد هيتكلم على تروكانتريك فراكشرز. بعد كده الدكتور اسامه هيتكلم عن الرول اوف انتي كواجولانتس. نخلي بالنا ان في جريت رول اوف بروفيلاكتيك انتي كواجولانتس في البروكسيمال فيمورال فراكشرز. بروكسيمال فيمورال فراكشرز احنا عندنا نسبه قد تصل في حدود 35% لحالات احتمال يحصل لها دي في تي، وعشان كده الحقيقه احنا حطينا الموضوع ده في نفس التوقيت بتاع الويبنار بتاع البروكسيمال فيمورال فراكشرز. والنهارده الدكتور سامح اتكلمنا على الاورال انتي كواجولانتس وعلى راسهم طبعا الابيكسابان. بعد كده هتكلم انا على الرول اوف اكسترنال فيكسيشن ان بروكسيمال فيمورال فراكشرز، برغم ان بعض الناس بيعتقد ان هو ملوش اي رول، بس احنا هنتكلم طبعا، انت عارف سويمنج اجينست ذا كارنت، احنا بنحب نسبح عكس التيار. هنتكلم عن الرول اوف اكسترنال فيكسيشن، وبعد كده انا هعرض حاله ونتناقش مع الساده الزملاء ومع الاتنديز طبعا، يقولوا لنا يبعتوا لنا رايهم ونناقش الحاله اللي هي اللي موجوده. بسم الله الرحمن الرحيم. طبعا هنفتتح الكورس بالمحاضره للاستاذ الدكتور عصام الشريف. اتفضل دكتور عصام. المؤاخذه استاذ الدكتور عبد السلام، دكتور علاء الزهيري هيتكلم على الفراكشر نيك فيبر. معلش يا دكتور عصام هننتظر شويه. اتفضل دكتور علاء.
بعمل بقى شير سكرين دوست عليها. ايوه كده الصورة واضحة يا دكتور جمال؟
لا لسه ما طلعش عندنا.
لا 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 على طول اهو ثانية واحدة.
نظرا لان في من الكورس في اعداد كبيره الحقيقه من بره، في ناس حاضرين الكورس من انجلترا، من امريكا، من اذربيجان، من عمان، اليمن، الهند، ماليزيا، اندونيسيا. فنرجو ان احنا نستخدم يعني نتكلم معظم المحاضره بالانجليزي يا دكتور علاء.
حاضر.
عصام، دكتور عبد السلام، كلامنا معظمه هيبقى بالانجليزي لان كتير من الحاضرين الحقيقه مش من المنطقه العربيه.
كده بانت يا دكتور جمال؟
مظبوط، اتفضل يا دكتور علاء، اتفضل.
كده بانت؟
بانت، اتفضل.
ماشي بيه. بسم الله الرحمن الرحيم. اولا طبعا بشكر شركه انسباير على الدعوه الكريمه للكورس بتاع الهيب، وطبعا بشكر الدكتور جمال على المجهود الحقيقه رائع. يعني في الويبينارز اللي شبه يوميه بيبقى فيه ويبينار واثنين وساعات ثلاثه كمان يعني. فهي فرصه طيبه للشباب يعني ان هو يجد الوسيله التعليميه الجديده اللي هي بتصل لغايه المكان اللي هو فيه، ونرجو ان هو يستفيد منها. فهنبتدي الويبينار ان شاء الله النهارده بالبروكسيمال فيمورال فراكشرز، وطبعا دكتور جمال قسمها لنا الى سيرفايكال فراكشرز، سيرفايكال نيك فراكشرز، والتروكانتريك والسبتروكانتريك فراكشرز. فلما يجي لنا سؤال زي ده على فراكشر نيك اوف فيمر، fracture neck of femur, you must divide into two types of patients. You have treatment of high velocity femoral neck fractures والجياتريك او الاولد aged patients. طبعا يختلف تماما اليونج عن الاولد ايج في التشخيص in diagnosis and treatment والكواليتي اوف بون. فهنشوف الكلام ده من خلال التوب بتاعتي. Learning outcomes, we have to specify the patient factors that impact the treatment decision and to compare closed reduction versus open reduction to achieve anatomical alignment. يبقى in young patients we aim to achieve anatomical alignment of the fracture to get the best function after treatment. We have to evaluate and plan appropriate fixation technique. Femoral fractures in young patients, the type of patients are active patients and they wanted to return as early as possible to their work. So they have better bone quality. Young patients have better bone quality and high energy trauma. So you have to search for polytrauma, combined injury pattern, and usually they have higher bowels angle. What are the treatment goals for treating young patients? We have to save the femoral head. First of all, the blood supply of the head must be saved to be viable head, and to minimize or avoid deformity like improving union.
my pleasure to give this lecture until Professor Alaa comes back. The topic of today is the current treatment and options of subtrochanteric fractures. What is the learning outcome of this lecture? To just study the structure and the biomechanical characters of this area, how to make the decision, how to position the patient, how to reduce the fracture, how to fix without palpating or IMN nail, and the outcome of plate when compared to nail, and some outcome publications. About the epidemiology of subtrochanteric fracture, it's more or less rare, from 7 to 34 of all femoral fractures. Females are a little bit more frequently affected fractures than males, with 1 year mortality after fixation of 25%, more or less like that of neck femur and trochanteric fracture. How to define subtrochanteric fracture? A lot of publications, but we agreed on 5 centimeter distal to the distal end of the lesser trochanter is considered as the subtrochanteric fracture. 5 centimeter distal to the distal end of the lesser trochanter. Above this, till the intertrochanteric line is a trochanteric fracture. From this one to the original side of the epiphyseal plate of the head is the neck fracture. Above this is the head fracture. The comprehensive classification of AO. If the fracture is simple, it's type A. If it is a wedge, it's type B. If it is multifragmentary, it's type C. And subclassification you can refer to. Most important is to know the deformity and the acting forces of surrounding muscles on the bone, because in order to reduce, we have to counteract the deforming force. We have to reverse it. The proximal fragment is abducted, flexed, abducted by the short abductors, gluteus medius and minimus, flexed by the iliopsoas, external rotated by the short external rotators, while the distal fragment is abducted by the abductors, shortened and external rotated. As we know, the mechanical axis of the femur passes from the head to the center of the head to the center of the knee. So it is medial to the shaft of the femur. So the medial cortex of the femur is under compressive force, while the lateral part or the lateral cortex is under distraction or tension force. So this area is peculiar of having high bending load, especially if there is lack of medial support. In addition, the blood supply of this area is a bit deficient. It is of a small diameter. These facts add to the difficulty of managing such fracture. So, if we are going to choose an implant to fix this fracture, we have to choose a mechanically strong implant that can tolerate the bending force. There is a tremendous force even during walking and normal activity. Next point, how to position the patient. We can position the patient either supine or in a lateral position. Each one has got its merits. Supine position is very suitable for multiply injured patients. You can manage other fracture. If the patient is having a fracture spine, it is more suitable to put him in a supine position. You can have a good control over the rotational alignment in nailing in the supine position. You can apply traction in highly muscular patient, and you can apply a traction table better in a supine position. Lateral position is more suitable for fat patients, especially for piriformis injury of a knee. It allows more control of the sagittal reduction. At the end of the day, you choose the way you are familiar with and you are happy with. Again, you can use a regular table and you can use a traction table. Regular table allows for reduction of the fracture. Traction table is advantageous in allowing distraction force and aiding reduction, and you can dispense with an assistant to reduce and to apply continuous traction. Now, as we know, the proximal fragment is flexed, external rotated, and abducted. There are many ways to reduce without opening on the fracture. In very same patient with poor musculature, you can just press on this fragment through the skin, and usually this technique fails. You can use a hook to pull on this fragment. You can use a shank with attached T-handle to manipulate like a joystick. You can use a femoral distractor. You can use two shanks with two T-handles to manipulate the fragment, considering the future path of the guide wire or nailing. You can use plate indirect reduction technique by using the shank through one of the holes of the plate to avoid cutting through during distraction. You can use an external fixator for manipulation. You can use even some towel to pull on the fragments. Again, you can use a point pusher and a hook, and you can use any other instrument. And if you fail with all of such instruments, you can open a small wound and do open reduction. Because nail is not a reduction tool. You have to achieve proper reduction before embarking on nailing. Now, what are the available treatment options for subtrochanteric fractures? Conservative or traction is rarely used only when the anesthetic risk is very high, or if the patient is bedridden. Even in such patients, surgical treatment will facilitate nursing. The other two techniques, either external fixator, which would be left for Professor Gamal, and internal fixation. Internal fixation either using a plate or a nail. Plates are used when there is a complex problem and for salvage of failed other techniques. I will show that in some examples. Nailing is the gold standard for subtrochanteric fracture. Why? Because it's the load sharing, and now early weight bearing and rehabilitation. There is lower incidence of non-union, hardware failure, loss of alignment, plus low infection rate and low blood loss. These are different bills. DHS, which is mentioned to be condemned. The failure rate is exceeding 50% with DHS in subtrochanteric fractures. Fixed angle implant like DCS and dynamic and the condylar blade. I will speak later on such modes of fixation. Modern blades like anatomical proximal locked femoral blade, almost recent reports almost denote around 35% failure rate. Maybe because those screws are in one plane and they are entering from a very weak cortex, and ending up in a very weak bone. So at the end of the day, this implant is no more used. The failure rate is exceeding 35%. This is an example of plating as a salvage for difficult cases. This was subtrochanteric fracture fixed by proximal femoral nail with breakage of the nail and non-union of the fracture. I think you can't repeat the same procedure. As Einstein said, insane is to repeat the same procedure expecting another outcome or a different outcome. So I've treated such condition by condylar plate. The secret is to compress the fracture and whenever possible, use a leg screw, absolute stability. Another case of failed condylar plate, there was a previous surgeon. In spite of having a hypertrophic non-union, the surgeon did a bridge plate. So it failed again and the plate was broken. The salvage was another condylar butt with compression and absolute stability. Another case of subtrochanteric fracture with trochanteric extension. The fracture was not reduced. In trochanteric extension to the greater trochanter or into the piriformis fossa, it is not advisable by many literature to do a nail. So here it ended up with non-union. The nail was thin. It is a reconstruction nail. The solution was to relocate the fracture, reduce the fracture, and achieve stability by broad DCB with a staggered hole in front and behind the nail, and it united in 3 months. Another case, as was mentioned, we need a strong implant. Here the surgeon uses a narrow DCB, a very weak implant. So it ended up with bending of the implant and non-union. The solution was to have a strong implant and compression. Another case of metal breakage after condylar plate. The solution, that is, of course, a coxavara around 90 degrees. You have to improve the mechanics by valgus deformity, by inducing valgus correction by a DHS. This is a reclination osteotomy, and DHS, the idea is to have another screw in the proximal fragment, like to prevent, because the DHS is rotationally unstable in the proximal fragment. If you add 1 or 2 screws, it would be rotationally stable. In the previous X-ray, you have the path of the condylar. You can't have 2 passes for condylar plate. So we have chosen another path by DHS application. Another case of failed DCS, revision by condylar plate with compression. Another case of proximal femoral nail with non-union, removed, and during its removal we have discovered that the X-ray was old and the nail was broken. We succeeded to remove, of course, the proximal part of the nail only. We left the distal one, and we applied a condylar plate with progressive union. In a study of subtrochanteric fracture of the femur, in one study, 47 cases, non-union rate was 17% in 23 of the cases, or 24 that underwent indirect reduction got no non-union. So the secret in plating is to have indirect reduction without violation of the soft tissue. So plates perform well with less invasive surgical techniques. Nails, as we have said, are the gold standard. They fail much less than plates. The rate is from 3 to 5% failure. But recently has been shown that in big studies that they are not so excellent. In one study of 60 cases, 19 of them, they got virus of 10 degrees. And they have all complications, renal union, toenail breakage in a virus group. So in comparison, in another study comparing nail to DCS plate, there is almost no significant difference, provided that the plate respects the soft tissue. This is an example of a bridge plate, not through minimally invasive technique. Almost the results are the same, plating and nailing. Shen compared also in 2017 outcome between biologic plating and nailing, and he found no significant difference in bone union, time to union between the two different fixation techniques. But coronal alignment seems to be better in plating than in nailing. I mean, in nailing, there is a higher incidence of varus malunion. Again, plate or nail. Both perform well, but avoid varus in nailing and do a biological plating, unlike this case of white non-biological plating. Which implant to use? This is a complex question, and the literature can't provide appropriate answers. According to basic principles, however, some guidelines can be set. Blades should be strong enough and long enough, especially if the medial hinge is broken. Biologic plating is preferred. Nails should be also long enough, and the locking options could be standard parallel screws if the lesser trochanter is intact, or reconstruction through the neck and the head if the calcar is deficient. So decision making also depends on bone quality and the fracture pattern. If there is a poor bone quality, like fragility fracture of bisphosphonate long-term therapy, nailing is preferred. Simple fractures, both are good, nail and plate. Trochanteric extension, especially into the piriformis fossa, plating is preferred. Presence of neck femur fracture, plating is indicated in association with subtrochanteric fracture. Any contraindication for nailing, like a very narrow medulla or a deformed medulla, plating is preferred. Complex fracture will prefer nailing. In plating, again, biologic technique. These are just points to remember. Take home message: understanding the fracture anatomy and the inherent deformity is the key to success. You reverse the mechanism of trauma. Eccentric mechanical loading poses a very strong load over the implant. So a long nail always safe, but avoid malreduction. Plating through less invasive technique is reduction is the key. Could be difficult in the supine position. Could be used, and the choice of the surgeon is a decisive factor. Cephalomedullary nails, if used well, are marvelous tools for subtrochanteric fractures. Conventional blade screw may be used, but need very careful management. Quality of bone and fracture pattern may help in decision making. Thank you very much.
Thank you, دكتور عصام.
أكمل يا دكتور جمال.
دكتور علاء دلوقتي. Professor Alaa is going to continue his lecture. Professor Alaa. واضحة تمام، اتفضل.
We are speaking about fracture of the femur. We classify the patients into two types: young age geriatric patients. We are speaking now about young patients or adult patients. What are the complications? Femoral head viability, 10 to 27% avascular necrosis. Fracture union, we have 10 to 20 cases percent non-union. What are the treatment issues? We have to preserve the femoral head viability, timing of surgery. This is a very important question. The aerial is better when you go early for treatment of these cases. It is better. 13 out of 15 did well. If done operation at 8 hours in the operating room. Role of operation, experimental data support early operative intervention, but what are the treatment algorithm for these cases? Surgical urgency trend towards better outcomes with early surgery. Radio translucent table for facilitating imaging during operation. Supine on regular or orthopedic table allows for full manipulation of the fracture fragments. And open reduction, better exposure to ensure anatomical reduction and the compression of the hip capsule. يبقى في اختلاف واضح هنا في اليونج age ان have to do the operation by anatomical reduction, early intervention, opening the capsule for the decompression, and better to be by open reduction for anatomical reduction of this fracture. To get an early and good function after operation, we are speaking about adult patients. Here is that radio translucent table facilitates imaging. Supine on regular orthopedic table allows for full manipulation of the fracture fragments. The treatment approach, anterolateral approach, avoid detaching the gluteus medius for better function after operation. Don't lose the abductors. Preserve the femoral head blood supply. Anterior approach exposes the fracture for reduction and percutaneous fixation. Here is an open direct reduction. We control the proximal fragment by Hohmann's retractor in the capsule or 2.5 millimeter Schwanz screw and manipulate the distal fragment by traction or 5 millimeter Schwanz screw in the shaft, like joystick. Provisional diagnosis by K-wires or guide wires for cannulated screws, 3.2 millimeter drills. After open reduction, we have to choose the implant. We have many choices for treating this type of fractures in adults. We are speaking about in adults. We have cannulated screws, 7.3 or 7 millimeter, or cancellous screw 6.5 millimeter or dynamic hip screw with or without the rotational screws. The implanted choices, the cannulated screws. What are the difference between cannulated screws and the cancellous screws? Cannulated screws is for placement, less cortical fenestration, and the thicker core diameter. Cancellous screws 6.5 millimeter, thinner core diameter, but have better compression. So each case has its implant to be chosen. Not all the cases like each other. Screw fixation, we have rotational control, compression at the fracture site, less bone removed, and works well for also subcapital fractures. Yet these screws works well as the subcapital fractures. How to put your screws? Study the fracture pattern for optimal placement. You have to go inferior in the neck along the calcar as much as you can. As you see, study the fracture pattern for optimal placement. Inferior along the calcar and posterior along the neck. You have to get the image working with you. So, after studying, as I told you, it is the screws inferior along the calcar, posterior along the neck. The superior screw at the central surface, this screw must be as a fracture, and all screws are perpendicular to the fracture line for better compression. Also, we have this screw in some cases, what's called the bowels screw. So these are the 3 screws, and this is the bowel screw. So, in some cases, we may use a dynamic hip screw. Yes, better varus control, greater volume of bone is removed. The rotation screw is essential and best used in the basic cervical fractures. In failure of judgment, basic cervical fracture treated with cannulated screw, like this case, treated by cannulated screws, we have to salvage by valgus osteotomy and conversion by blade, as you see. So in summary, for treating fractures in adult cases, treatment priority is femoral head viability, surgical urgency as much as you can, open reduction is better, rigid fixation, and the preservation of the femoral head leaves option open for salvage. After we finishing the fracture in young or adults, we have now to speak about fractures in the elderly patients. Here is a big difference in diagnosis in treating these cases. We are speaking in the adult cases by screws or DHS, but here we are speaking about repair of the fracture or replacement of the joint. So the learning outcome for the elderly patients, we have to choose the proper treatment option, assess factors for this decision making, and evaluate the key outcome from publications. Fracture neck of femur in the elderly, increasing in prevalence because all these patients are osteoporotic, and this is the next big epidemic all over the world. This is a case, 78 years old female, fell in the home, limited mobility, using a walking frame at home, multiple medical problems as usual, how to treat her hip fracture. Very, very important questions in the exams and everywhere. You have to know the anatomy and the blood supply of the proximal femoral area. Please, we are not going to discuss this in the lecture, but to have to give you awareness about this very, very important question in the exams, clinical, oral, operative. This is a very common question. You have to know well the anatomy and the blood supply of the proximal. Here is the femoral neck fractures. Several classifications exist, but all divide fractures into two main categories: non-displaced or stable fractures, or displaced fractures. The most common classification is Garden classification, which was put at 1961, Garden 1, 2, 3, 4, but it has a high degree of inter-observer variation. Difficult to predict the complications, especially grade 3 and 4. In practice, usually surgeons only distinguish between undisplaced type 1 and 2 and displaced 3 and 4. The treatment options: non-operative, if medically unwell, unable to walk; internal fixation; hemiarthroplasty; total hip arthroplasty in these cases. If we choose implants like screws, we have to choose parallel cancellous screws. We have a question here: is it 2 or 3 or 4? Usually 3 screws are enough to treat these fractures, but you have to make your orientation of placement of these screws. Clinical data has no proven benefit for inserting more than 3 screws. So usually we put 3 screws, not 2. We have to put 3 screws, and sometimes we put a 4th screw in some cases in posterior comminution of the neck. So biomechanical data shows that 4 screws are more stable in fracture with posterior comminution of the neck. Consider dynamic hip screw in cases also of posterior comminution. Like this. If dynamic hip screw is used, remember to use the rear rotation screw, very, very important to prevent rotation. Increase ABN rate, increase the non-union rate, high ABN incidence if nail is positioned superior laterally in the neck. Choice of the implant for internal fixation, meta-analysis, no difference between screws or DHS, the same results. Capsulotomy, it is a must in adult patients, as we told you in my presentation. But here is controversial. Relieves intercapsular hematoma, no evidence base for use in these cases, considered only for younger patients, capsule decompression, open reduction and internal fixation, quality of reduction, most important factor in good outcome. Acceptable reduction in all the patients. That's the big difference between adult and all the patients. We have acceptable reduction, not anatomical reduction. With 10 degrees valgus angulation, but we don't accept the varus. Less than 10 degrees anterior or posterior angulation. In cases of displaced femoral neck fractures, open reduction, internal fixation complications, usually in old age, 15% loss of fixation, 15% avascular necrosis, and 30% non-union. So, open reduction, internal fixation, or arthroplasty in old age. several prospective randomized controlled trials, no clear overall advantage. Hemiarthroplasty, I put this for historical Boston Moore. Many of you, I think, don't know about this, young or new generation doctors. This fixed unipolar, this is called Boston Moore, condemned now, not used. This modular bipolar, and this is the bipolar. Approach, anterior approach, anterolateral approach, lateral approach, posterior higher incidence of dislocation. So we have to use bipolar or unipolar. We thought that bipolar becomes unipolar within months of movement. So have no benefit to use the bipolar. No difference in dislocation, acetabular erosion, wound infection, re-operation, and the DVT. Mortality also, walking or functional outcome. So unipolar, the same results like bipolar, which after some months will change into unipolar. But difference is cost, because bipolar is more expensive than the unipolar processes. Cemented or uncemented. We are speaking about elderly patients. Cement advantage, immediate stability, possible decrease the pain and the loosening. Cement disadvantage, time, cost, and the very important is the cardiac arrhythmia and the cardiorespiratory collapse, marrow embolism. So have to use also total hip arthroplasty in treating these cases. When a total arthroplasty is indicated, total hip arthroplasty best in selected patients that mentally alert, healthily, and ambulance, rehabilitated like active total hip arthroplasty patients, lowest level of revision and the longest supervision. This is the case of 78 years old female, fell at home, limited mobility, uses a walking frame at home, multiple medical problems. So if you have a case of geriatric old age, you have to ask yourself some questions. How to classify first this injury? What is the treatment options? What is the timing of this treatment? How to manage medical comorbidities? What about anesthesia? What approach? Open reduction, hemiarthroplasty or total hip arthroplasty, cement or non-cemented, and also DVT prophylaxis, weight-bearing status. So the final is the treatment algorithm. If under 55 years old, we have to go to DHS with derotation screw. From 55 to 85 unipolar prosthesis, and over 85 years we go to the total hip arthroplasty. This is the age algorithm for treatment. We have to know that all the people are active in society and they need the best care. So in summary, femoral neck fractures are either non-displaced or displaced. Open reduction internal fixation should be reserved for healthy young patients. Open reduction internal fixation has best results with anatomical reduction. Replacement has better functional results in older patients. Use cement in healthy patients. Consider total hip arthroplasty in healthy femoral neck fractures patients. Bipolars have little evidence base for use and is very costly. And thank you for listening to this lecture. And I'm going to now to Dr. Gamal Hosny.
Thank you, Professor Alaa. We will postpone the questions till the end. If you have any questions, you have to send it through Q&A. Now, the third lecture in this webinar is Professor Abdelsalam Eid. Professor Abdelsalam, please.
Thank you, Professor Gamal. It's an honor to be with this distinguished panel. My dear colleagues and friends, Professor Essam Sherif and Professor Alaa El Zoheiry, as a part of the ongoing activity of the EOA. They were going to speak about intertrochanteric fractures. In this lecture, we are going to speak about the mechanism of injury, the classification scheme, stable and unstable fractures, treatment goals, treatment options, complications, and finally, salvage procedures. Intertrochanteric fractures are extracapsular fractures which extend to the inferior border of the lesser trochanter. These are figures that are copied from the American literature. There is about 250,000 hip fractures per year, which are expected to double by 2040 to 500,000 fractures, 50% of which are intertrochanteric fractures. More than 90% are above 65 years old, females more than males, of course, because of the post-menopausal osteoporosis, and there is a peak around 80 years of age. The etiology, there are contributing factors such as osteoporosis, usually comes from a low energy fall, elderly people falling at home while going to the bathroom at night or something. Rarely it's due to high energy, and this usually in young patients. We need to know a little bit about prevention. Can we prevent intertrochanteric fractures? There is a few things we can do. We can actively treat and try to prevent osteoporosis, because this fracture is related to osteoporosis. If you can effectively treat osteoporosis, then you will decrease the chance for intertrochanteric fracture. And as you know, all medications for the treatment or prevention of osteoporosis, they all speak about reduction of the risk of fracture. So if you treat or prevent osteoporosis, this is a very good step in the prevention of intertrochanteric fractures. Also, fall prevention. This is something that needs to be taught to elderly people living in small homes crowded with furniture. They should clear pathways and remove rugs and stuff that will cause the elderly person to fall down. Like I said, usually going to the bathroom at night, it's important to use a walking stick if somebody needs a walking stick, or handrails and something, because this usually helps prevent the falling of this elderly person, which will lead to the intertrochanteric fracture. Finally, minimize fall impact in, there are some people who speak about pads and stuff, but this is not such a big deal. How do they present the intertrochanteric fractures? They involve the extremities short and externally rotated. We do plain radiography. Usually this is enough. There is very little indication to do further investigation for intertrochanteric fracture. Little indication to do, for example, CT. Usually AP and lateral views are sufficient to diagnose and classify the intertrochanteric fracture. In occult fracture, you may resort to bone scan or MRI, but this, again, as I said, in occult fracture, not in the obvious one. These patients, like I said, they are usually elderly patients and they need to be prepared, because if we are going to perform an operation, they need to be prepared thoroughly, like medical consultation, DVT prevention, antibiotics, treatment of urinary tract infection, and nutritional optimization to decrease the post-operative mortality. Now we move on to the classification of intertrochanteric fractures. And there are multiple classifications of intertrochanteric fractures, but what I want you to learn from this lecture, very important, distinguishing between two major classes, stable and unstable fractures. Stable and unstable fractures, we are going to use these terms repeatedly in this lecture. There is the Evans classification, there is the AO-OTA classification. The Evans classification classifies the fracture first in the unreduced and then after reduction position or X-ray. There is the undisplaced fracture, which is stable fracture, and it remains the same position if you try to reduce. There is the displaced reduced. It is displaced, but if you reduce it on the traction table, there is continuity on the medial cortex, and this is a stable situation. Then there is the displaced, not reduced. If you try to reduce it, and despite anatomical reduction, it tends to go into varus. There is no contact on the medial cortex. Then, and this is an unstable type of fracture. Then there's a comminuted, of course, this is unstable. And then there is the reversed obliquity, which is, of course, also unstable. The AO-OTA classification classifies trochanteric fractures as type A extra-articular. There is A1, A2, and A3. The A1 is a two-part fracture. There is no comminution, and the fracture does not enter the lateral cortex. Please keep in your mind this expression, the lateral cortex. We are going to elaborate more about the lateral cortex in the coming slides. So the fracture does not enter the lateral cortex, and it is a stable fracture. The A2 is also a two-part fracture, but there is a little bit of comminution, but still the fracture does not enter the lateral cortex. However, because there is comminution and there is lack of continuity on the medial cortex, it is an unstable pattern of fracture. Then the A3, it's a two-part fracture, and there is comminution, and the fracture enters the lateral cortex. And an example of this is the reverse obliquity fracture, as it exits through the lateral cortex here, and this is an unstable pattern of fracture. So we speak about stable and unstable patterns of fracture. What is a stable fracture and what is an unstable fracture? The stable fracture resists the compressive loads. You know, the body weight comes from up here and it goes through the neck like this, and it produces two forces, one force of compression that compresses the fracture and one force that causes shear and displacement. So in stable fractures, there is a lateral cortex, and this lateral cortex supports this head-neck fragment and prevents collapse, and also prevents medialization of the shaft. With anatomic reduction and fixation, the compressive forces will compress the head-neck fragment into this lateral cortex, and this is a stable situation. This is an unstable situation. There is no support, and there is collapse in varus. The force is mainly causing varus collapse. The shaft is displaced medially, related or relevant to the head-neck proximal fragment. Despite anatomical reduction and fixation, so even if you do anatomical reduction and fixation, you may end up with this situation in an unstable fracture. So this is why it is very important to know from the start if this is a stable or unstable pattern of fracture. What are our goals of treatment? What do we need to do with this fracture, and what do we need to obtain from treatment? We need to obtain a stable reduction that will not go into collapse. We need the internal fixation to be in good position and to be mechanically adequate fixation that will permit immediate transfers and early ambulation. Transfer, I mean with transfer from bed to wheelchair to go to the bathroom, etc., turning patient in bed, and early ambulation, of course, and this also includes non-weight bearing mobilization and early ambulation as soon as possible. What implant options do we have? We have the dynamic or compression hip screw with side plate, or commonly known as the DHS. Also, we have intramedullary devices. Also, we have arthroplasty. The dynamic hip screw with side plate leads to controlled impaction of the fracture. What do I mean by controlled impaction of the fracture, and why is it called dynamic? This is a very important piece of information. Please listen carefully. As we said before, the body weight comes and the force of the body weight is divided into two forces, a compression force and a displacement force. If the DHS here is in higher angle, it is in line with the compressive force. This is why higher angle of DHS have greater tendency for impaction. You all know the 135 DHS side plate, but there's also the 150 DHS side plate, and there is in some companies the variable angle DHS side plate. So if you produce higher angles, this higher angles goes more in line with the body weight, and therefore it produces more impaction. And this is why after you finish your work in the operation room and the patient goes back to his home, the dynamic hip screw still allows the controlled collapse of the fracture. Therefore, it is called dynamic, because the situation you end up in the operation room immediately post-operative may change after some time, and you find that this fragment together with the leg screw have collapsed, and you sometimes find the screw exiting from here and the situation has a little bit changed. This is what is called dynamic, because it continues to work after you finish your operation. Now we need to talk about how to position the DHS. The leg screw needs to be centered, where not in the femoral neck, but it needs to be centered in the femoral head, both in the AP view and the lateral view. Please, this is very important. We should center the leg screw in the femoral head, not in the femoral neck. And therefore, a higher angle implant usually can be centered more easily in the head than a lower angle implant. But what is the drawback of the higher angle? The higher angle implant, like the DHS 150, will be inserted from a lower position, usually near the subtrochanteric area. This will produce a stress riser. This may produce a fracture later on. But a lesser angle, like the 135, is still functional, and it avoids the drawback of the high angle. What about the tip apex distance? You have all heard about the tip apex distance. Actually, the first time the tip apex distance was mentioned, it was mentioned retrospectively. This is some researchers, they brought X-rays of DHS, which went well, and others which failed. And by studying these X-rays, they found that if you measure simply the distance between the tip of the screw and the apex of the head in both the AP and the lateral view, this is the apex of the head and the tip of the screw, they both should be within 25 millimeters combined. This lessens the chances for failure. So there is less failure if the tip apex distance is less than 25 millimeters. If it exceeds 25 millimeters, there is higher chances for failure. So this was discovered or this was mentioned by researchers who studied X-rays, but now you can use it intraoperatively using the image intensifier to judge the proper position of your leg screw and whether you should change the position of the guide wire to get a better position of the leg screw or not. Now we move on to a very important landmark of this presentation. This is a paper in Bone and Joint Journal. Bone and Joint Journal, and it speaks about the lateral femoral wall thickness as a reliable predictor of post-operative lateral wall fracture in intertrochanteric fractures. As I said before, we should study and find what fractures are stable and unstable. These researchers here have studied a lot of intertrochanteric fractures and found that the thickness of the lateral wall, if it is at least 20.5 millimeters, I mean, this means 20 millimeters, this means 2 centimeters. This thicknesses 20 and more have a good support of the lateral cortex for this proximal fragment, and therefore it does not collapse and the lateral wall does not fracture. Where do you measure this 20 millimeter? You take a point 3 centimeter from the this point of the innominate tubercle of the greater trochanter, 3 centimeters down, and you project a line like the line of DHS at an angle of 135 degrees. You measure this distance on the X-ray. If it is 20 millimeters or more, this is a good lateral wall that will support this DHS. I will repeat this piece of information in Arabic because I think it's a very important piece of information. اللاترال كورتكس دي بتنزل 3 سم تحت الفلير بتاع الجريتر تروكانتر هنا، وتاخد لاين كانك انت بتعمل دي اتش اس. اللاين ده 135 درجه، وتقيس الحته دي، المسافه دي المفروض تكون 2 سم فما فوق. لو اقل من 2 سم يبقى انت تخيل انت هتعمل في الحته دي فيري بيج هول عشان تدخل السايد بليت. الحته دي ممكن تكسر بسهوله. في الحاله دي بقى الفراكشر بتاعك بدل ما هو ستيبل قلب انستيبل لانه عمل فراكشر لللاترال لللاترال كورتكس. This is an example of a good lateral wall, and this is an example of a thin lateral wall, and this will fracture and fail. So the rule is, if there is no lateral wall, there is no hip screw. No lateral wall, no DHS. Again, no lateral wall, no DHS. So this is when there is reverse obliquity fracture. Like I said before, the reverse obliquity fracture exits through the lateral wall. Transtrochanteric fractures, which are transverse fractures between the two trochanters, also exit through the lateral wall. If there is no lateral osseous butters, and therefore, if you use DHS, what will happen? We will have medial translation of the femoral shaft and lateralization of the proximal femur. يعني لو انت استخدمت DHS في الفراكشرز اللي ما فيهاش lateral wall دي، هيحصل ايه؟ هيحصل medial translation للفemoral shaft والlateralization، يعني failure. This will lead to deformity, non-union, screw cut out. So in these cases, it is better to use what? An intramedullary device. Know the unstable intertrochanteric fracture patterns and nail them. This is the second rule. So again, you should know from the X-ray which fracture patterns are unstable, and you do not use DHS in these fracture patterns. You use an intramedullary nail better. Like this reverse obliquity fracture, it exists through the lateral cortex. If you use DHS, it will fail. The reverse oblique fracture have a fracture in the lateral cortex, unstable with hip sliding hip screw. You use intramedullary nail or fixed angle device, because this will produce lateralization of the proximal femur and medialization of shaft. In reverse oblique fracture, you use a DCS, a plate like Professor Essam Sherif showed us, an intramedullary nail. These implants resist medial shaft displacement, resist the medial shaft displacement. Trochanteric fractures, which are transverse fractures exiting here through the lateral cortex, also end in varus collapse and are unstable patterns and should not be treated with DHS. Fractures with a large posteromedial fragment. We said in the beginning of the lecture that we need to have a continuity or a contact on the medial side. If you have a large posteromedial fragment or a lesser trochanter fragment, you have high chances of varus collapse. Subtrochanteric extension, of course, these fractures are also very unstable fractures and cannot and should not be treated with a DHS. So the intramedullary hip screw or the PFN or the gamma nail or whatever you call it, it has decreased implant bending strain. What do you mean by decreased implant bending strain? The body weight comes here, and it produces a bending effect on the leg screw. If the plate is here on the lateral cortex, there is a long lever arm. I will repeat that in Arabic in a few moments. There is a long lever arm of the force of the body weight, which causes bending over here, over the implant. It will produce implant failure. But here, if you choose an intramedullary device, it is closer to the force, the axis of the force, and therefore it has a shorter lever arm. بالعربي كده الكلام بتاع الميكانيكا بتاع زمان، القوة في ذراعها. لو احنا قلنا القوه بتاعت البودي ويت جايه كده، ولو انت حاطط شريحه DHS يبقى المسافه دي كلها هي ذراع القوه، يبقى انت المحصله بتاعتك كبيره. بينما انت لو حطيت الانترميدالري ديفايس دي المسافه دي اقل وبالتالي المحصله اقل. Of course, intramedullary hip screws can potentially be inserted percutaneously. I mean, you can insert it percutaneously. This is the original concept. Of course, they are very useful if you have an intertrochanteric as well as a subtrochanteric or shaft. You cannot use a DHS if you have such a fracture, but it's better to use an intramedullary hip screw or gamma nail or whatever. In reverse oblique fracture, and of course in pathologic shaft fractures. In pathologic shaft fractures, you need to fix from the head to the condyles. And this is why you need fixation in the femoral head and neck, and you use an intramedullary hip screw or gamma nail or recon nail, etc., along one to fix the pathologic fracture. Tips for nailing. These are technical tips. Beware of the anterior bow of the femoral shaft. You should take a lateral view of your femoral shaft, because if you are going to use a long intramedullary hip screw, you may penetrate. If there is a significant anterior bow of the femur, you may penetrate the anterior cortex. Number two, when using a trochanteric entry nail, we know that the gamma nail or intramedullary screws, they have a trochanteric entry, but you should try to start a little bit medially, not through the piriformis, but a little bit medial to the shaft, because the mass of soft tissue and the positioning of the patient usually cause you to deviate a little bit to the outside. So if you start more laterally, you will cause more lateral widening, but you start a little bit medial to the tip of the greater trochanter. This is a very important piece of information. Do not ream an unreduced fracture. The treatment of the proximal femoral fracture begins with a good reduction, and if you cannot obtain a good reduction closed, you can open and produce an anatomical reduction. If you ream an unreduced fracture, the nail will go in this position, and you will have malreduction even though you introduced a nail. And as Professor Essam Sherif said, the nail is not a reduction tool, not in the proximal femur. You may use the nail as a reduction tool in the shaft because the shaft is a narrow cylinder and long one, but in the proximal femur, you cannot use the nail as a reduction tool. You need to do your own reduction, and then you ream, and then you insert the nail. And when you insert the nail, please do not use a hammer. You use hand manipulation to seat the nail. Avoid varus angulation of the proximal fragment at all costs. And to know if you have a varus reduction, use the relationship between the tip of the trochanter and the center of the femoral head. We all know that the tip of the trochanter is almost opposite the center of the femoral head. التب بتاعت الجريتر تروكانتر قصاد السنتر بتاع الهيد. فلو لقيت ان التب بتاعت الجريتر تروكانتر اعلى من السنتر بتاع الهيد يبقى معنى كده ان انت عندك فيروس. Avoid fracture distraction while nailing. Avoid fracture distraction while nailing. Finally, we speak about prothesis, calcar replacing, because you need to replace, because there's an intertrochanteric fracture, you need a calcar replacing prothesis. It's indicated in pathologic fracture, severe osteopenia, severe comminution, rheumatoid arthritis, and its benefit is early weight bearing. But indications are not so common as internal fixation. Rehabilitation, we need to mobilize early and weight bearing as tolerated. If the fixation fails, we may need to salvage with another fixation or an arthroplasty. So the take-home message is know the stable and unstable fracture patterns. Again, please know the stable and unstable fracture patterns. The stable fracture patterns can be treated with the DHS. The unstable fracture patterns need an intramedullary device. Lateral cortical thickness, minimum 20 millimeters. Again, lateral cortical thickness, we said that we measure it 3 centimeters below the innominate tubercle of the greater trochanter in a direction like the DHS leg screw. It should be at least 20 millimeters. And remember when not to use the DHS, when not to use the DHS. Thank you very much.
Do we have a role for external fixation in proximal femoral fractures? We are going to speak about it now. Application of external fixation, it seems like an everybody's job. So patients, surgeons professional in internal fixations, they do external fixation. Pediatric orthopedic surgeon, they do external fixation. And when they teach the doctors working in the emergency room, they teach them that it's very easy to apply external fixation. Just 2 half pins above and 2 half pins below, and you put something in between. It's nothing to learn, it's nothing to teach. It's, it's easy, it's simple. It's nothing. Now let's talk about limb reconstruction surgery. Limb reconstruction surgery continues to affirm itself as a distinct subspecialty worldwide. This paper published 2017 in the Journal of Bone and Joint. What's new in limb lengthening and deformity correction? And in the introduction, they speak about the very popular annular deformity courses, Baltimore, Hull, and Cairo. Because every year, the Egyptian Orthopedic Association organizes an annual deformity course. And it's one of the most famous in the whole world. This year, we are going to have it physically. The 16th Cairo Deformity Correction Conference, 7, 8, 9 October 2020. And we're expecting everybody to attend. زي ما انتم شايفين مجلة البون اند جوينت أكبر مجلة في جراحة العظام، منشور مقالة على الجديد في التطويل والليمب ريكونستراكشن، وكاتبين فيه إن من أهم الكورسز في العالم كورس بولتيمور وكورس هال والكورس بتاع كايرو والباقي. عايزكم كلكم تحضروا هذا الكورس. We hope to see this picture again. نفسنا نشوف الصورة دي تاني، إن شاء الله هتشوفوها. فعايزكم كلكم تحضروا إن شاء الله our deformity conference في أكتوبر الجاي. So I know that you want to learn external fixation. Is it hard to learn external fixation? It depends upon the surgical training. بعض الناس يقول لك أنت لازم تبقى موهوب ولازم تبقى عبقري. Surgical experts are they born or made؟ يعني أنت بتتولد عبقري بتتعرف الجراحة ولا أنت بتتعمل؟ Surgical experts are made, not born. محدش مولود بيعرف يشتغل external fixation يا جماعة. خلي بالك monkey can operate. You can teach a monkey to operate. It's very simple. But somebody has to teach you how to do it. The most important thing if you want to learn this profession is the follow-up. It's a post-operative problem. It's not an operative problem. Going back to the fracture of the proximal femur. We've seen the classifications before from Professor Alaa, Professor Essam, and Professor Abdelsalam Eid. All of them, they spoke about the bony injury. How do you classify the injuries? But there's something missing, the soft tissue injury. Even if you have a closed fracture, you have an underestimated soft tissue injury. And we know that the classic treatment is open reduction and internal fixation, but this is double-edged sword. You have many advantages, but for sure, if you do an open reduction and internal fixation, you do more soft tissue injury. This is iatrogenic soft tissue injury, whatever the magnitude of injury. So let us speak about closed reduction. If we speak about external fixation, we speak about closed fraction. The real merit of external fixation is the ability to do closed reduction without any surgical exposure of the fragments. So there is no harm to the soft tissue. You don't increase the soft tissue injury. So the real merit of external fixation is the closed reduction techniques. No more. Unfortunately, when the people talk and when they teach external fixation, they don't speak about the closed reduction techniques because they don't do it. The external fixation role may be temporary or definitive. It's okay. Temporary in the damage control orthopedics, in polytrauma patients, in open fractures, infection. If you believe in two-stage treatment, we don't believe in two-stage treatment. If you have a firearm injury, it can be definitive. Early total care in polytrauma patients, open fractures, infection, if you believe in one-stage treatment, malunion, non-union, and I will show examples. We are not dogmatic because in some cases also I will show internal fixation. X-fix rule as a definitive treatment. I will teach you, I will show you how to do it as a definitive treatment. Because if you do it as a definitive treatment, it's easy for you to apply the external fixation as temporary treatment. And this is an example of trochanteric fracture and another subtrochanteric fracture. This is an open fracture. And this case, and I will show you also, this is a trochanteric fracture. This patient had infected total hip, total knee, which had been revised 3 times, and last time we have dislocated infected knee, and external fixator was applied, and 1 week after, the patient fell to the ground, which is very osteoporotic, and she had a fracture of the trochanter. And the surgeon was in panic. He thought that this is a disaster. How is he going to manage with this fracture? He's going to put a DHS or an intramedullary gamma nail or something. Now let's go back to the techniques of external fixation. This lecture is, the aim is the techniques. There are techniques for external fixation. External fixation is not 2 half pins above and 2 half pins below and something in between. External fixation techniques are not the techniques the AO teaches you. It's something else for sure. The first principle is the joint bridging or crossover. If you want to cross over the joint because of a comminuted fracture, you have a problem and you don't want to fix the fracture. This is the terrible example. They want to put temporary external fixation, and you see here they put half pins and they cross over the joint. But look here, pins in the fracture site, 3 pins in the fracture sites, dislocated or subluxed hip, severe infection of the half pins because they put the half pins in the same level. So this is a terrible example. This is a real example. If you want to put bridging fixator, 3 half pins, not in the same level, with angles in between. This is the stabular fixation. This is the suprastabular area. This is very hard area, triangle. And 3 half pins here. And if you want to build the femoral fixation, you can put your half pins suprastabular. You can use also the iliac crest. It's very easy. If you want to apply it in the iliac crest, you just pull the skin down by the thumb and the index fingers and make small incision and go by K-wire or just directly by the half pins 3 centimeters behind the anterior superior spines and the other half pins 3 centimeters behind. You can choose one of them. And this is an example of the firearm injury, a 15-year-old girl. And they applied in the emergency department in a hospital external fixation. And they removed the fixator, the fixation after 1 month, and they told the patient, your body did not accept the external fixation. And why? Because they told that this is the problem, that your body cannot accept it. You have severe infection, I have to remove it. The patient also has sciatic nerve palsy. Look now to we didn't have the X-rays during the application of the previous external fixation. But this is one of the half pins. You see this half pin. You see this sign, half pin going up in the superior part of the neck. And there are 2 or 3 half pins here in the shaft. So you put only 1 half pin here, and 2 half pins. Very unstable external fixation. And they call it external fixation. If it is not your cup of tea, it's not your cup of tea. It's simple. Anyhow, when she came to us, we ignored the sciatic nerve palsy because in our experience, now we've been dealing with many cases. Perhaps we had more than 500 cases in the last 8 years because of the conflicts in the area from high velocity firearm injuries. And this is low velocity, as you see here. We put 2 half pins in the suprastabular. 1 half pin in the direction of the neck, almost in the middle of the neck, reaching the upper part, subcortical area. This is the hard bone. Because we cannot put more in this proximal segment, we added supraacetabular part. If you cannot have a stable construct in the proximal femur, you have to go up to the supraacetabular part. Now, this is a stable frame. This is a proximal stable frame. 2 half pins in the acetabulum, supraacetabular, and 1 half pin in the direction of the neck. Now, when you fix it with key wires, the distal part, and we started distraction of this area, gradual distraction, 1 millimeter per day. We consider the comminuted fracture as a corticotomy, closed corticotomy. And we started distraction. During distraction, we pushed this distal fragment laterally to correct the alignment of the fracture. This is closed treatment of fracture. Again, the real merit of external fixation is closed treatment of fractures. It is not just to put 2 half pins above and 2 half pins below because you want to ablate later on after healing of the soft tissue. This is the way they teach us because they want everybody to put internal fixation. It's not real science. Now look to the picture after 3 months. Complete union. We almost have a normal neck shaft angle. It's a little bit less than normal. And we have the normal length. We didn't have shortening. We had recovery of the sciatic nerve palsy 8 months after the injury. And firearm injuries, we always wait and wait and wait because usually it's the velocity of the bullet which makes this some sort of neuropraxia. And you see the complete union, and this is closed treatment of fracture. And they told the patient, your body rejected the external fixator. Can you imagine? Funny. Techniques of external fixation. Another technique with the close reduction techniques. How do you reduce this patient was referred to me with this trochanteric fracture and severe osteoporosis. How would you manage with such a case? First thing, we don't remove this. We have to remove this half pin. It's in the fracture side. But we leave it in the beginning of the operation because of the stability. It adds something to the stability. And this is the fracture site, and you have a gap about 2 centimeters. We do some distraction first. And remember, this patient had infected revised total knee twice. And now the total knee is infected, and the patient was admitted and have external fixation to remove the infected total knee and do debridement and temporary external fixation. Now we have this picture. And this is the site of the knee after removal of the infected total knee, after debridement. So we have severe osteoporosis, severe chronic infection, and fat patient. The problem with the fat patient that you have the cantilever effect. There is a long distance from the half pin and the fixator. So this weakens the construct. So the decision or the plan is to do fixation by multiple threaded wires first. We have multiple threaded wires. Their size is 2 millimeters, 3 millimeters, and 4 millimeters. And sometimes in between. So our aim to go through to attach to the subcortical bone, because this is the only trustworthy area in this very osteoporotic bone. So our aim to put multiple key wires in the direction of the neck and to hold the subcortical. Then afterwards, we do traction to close the gap. And after we close the gap, we add multiple wires in different directions just to increase the stability. And maybe we can add half pins. So this is the picture during the operation. First, we applied multiple key wires and we closed the gap. And then we closed the gap by traction in the direction of the neck. So we closed the gap by the direction of the neck. It looks like you put a DHS and you close the gap by the DHS. Then you add more wires to add to the stability of these fragments. Then you remove the half pen, the offending agent here. Now we see we closed the gap. Then after we close the gap, we add more half pens to increase the stability of the frame. So proximally, we have multiple wires in the direction of the neck, other multiple wires here, and half pen. So this is a stable construct. Remember that we have rules of stability too. It's not only for internal fixation. Again, external fixations is not 2 half pens above and 2 half pens below, and put something in between. And look to the X-ray picture afterwards. The wires, multiple wires, 2 in the direction of the neck, 3 in the other direction, and a half pin. You see how we fixed the proximal fragment and we closed the distance, and this is the lateral view. You see the gap is almost closed in the lateral view. And we left this area because still we didn't have the healing of the, and this is after removal, complete union of the proximal fragment and healing of this area of the infected tutani. They didn't decide yet, and I left it for the patient, whether they go for the 4th tutani. The patient is 56 years old. She's too young, she's very fat. Patient, she's fat. And we left the choice for the patients after some time. The patient is abreast now, whether to do bifocal corticotomy and the close of the gap with arthrodesis, or to do the 4th tutani. Again, we have a fractured neck femur which had been treated elsewhere because this was an open fracture by external fixation. The so-called external fixation. This is how they treated the patient. This is the basal fracture of the neck femur. And another displays the fracture. Infected half pins, many infected half pins, many of them. And they told the patient he has to wait because this was a polytrauma patient. We are going to convert this external fixation to internal fixation. And now the patient is 3 months and they are waiting for internal fixation. And I will show you, I'm dead sure, if you put the patient in this infected frame for 3 months and they're going to put internal fixation afterwards, you are going to have disastrous deep infection. This is exactly what we did. We have multiple wires first, and we put cannulated half pin. Why we put multiple wires? Because we are not sure that this half pin will be infected, but it didn't. And we have complete union, and we put the frame down and gradual correction. And this is complete union of the fracture neck of the femur. This is the definitive treatment. And when they have the fixator for 3 months, they were waiting for more and more because they call it temporary external fixation. Now in open infected fracture, we have a trochanteric fracture and subtrochanteric fracture in the same patients. First, again, we put multiple K wires, first in the direction of the neck, and other K wires, we just left them there. We don't cross the gap. We crossed the gap after we had complete reduction or compression by the wires, threaded wires. And after we put the threaded wires, you see, we close the gap. See the lateral view, and we added half pins, but we have a displaced subtrochanteric fracture. So we changed the frame. So we corrected it 1 millimeter per day. It's in the sagittal plane. Again, we consider the fracture as a closed corticotomy, and by 1 millimeter per day, we reduce the fracture. You see here the reduction of the fracture. Fracture is reduced. other wires just for increasing the stability. And we follow up. And this is after union of both fractures. And this is the site of the open fracture. See how long this wound. Again, an indication is malunion of the proximal femur with severe deformities. This is the patient of congenital short femur, and she had fractured neck femur, which had been treated by plating and screws. But you see here, it's very difficult to apply a plate with this deformity and stiff hip. So this is this technique of applying the external fixation. We put a key wire in the direction of the head, then half pin. You see this half pin. Another half pin. And proximally, and we add the fracture, and we do displacement of the fracture, and we increase the angle. So external fixation has an important role in treatment of proximal femoral fractures, whether temporary or definitive. There are many rules to apply for the success of external fixation. External fixation is not 2 half pins above and 2 half pins below and something in between. If it is not your cup of tea, it's not your cup of tea. Thank you. شكرا يا جماعة. طبعا أنا هعرض حالة دلوقتي. I'm going to show a case and we can discuss. Now we know the basic principles from Professor Alaa El Zoheiry, Professor Essam Sherif, and Professor Abdelsalam Eid. And we're looking for the questions. Before we have the questions, we are going to show you this case and we discuss it. Then we discuss the questions. So, and again, we would like to stress on the importance of DVT in such cases. And now we know that the oral anticoagulant, Abdelsalam, has a rare role in management of such cases. This is a 22-year-old male which had been treated by DHS and derotation screw for basal neck femur. And after 8 months, he had ununited fracture neck femur and avascular necrosis of the femoral head. And with this displacement of the neck of the femur, what would you think? Professor Alaa.
وطبعا العمليه الدي اتش اس زي ما كنا بنتكلم انه لازم يبقى مكانه سنترال في الهيد اوف ذا فيمر، مش في النك كمان، يعني لازم في الهيد اوف ذا فيمر. فزي ما احنا شايفين البوزيشن بتاع النيل بتاع السكرو طبعا زي ما شايفين رايح فوق خالص، وبعدين الدي روتيشن اللي محطوط برضه مش في المكان الصحيح بتاعه، وبعدين دون unstable fracture من الاول، فده ما ينفعش فيه الدي اتش اس من الاول، يعني الديسيشن ميكنج ده unstable fracture ما ينفعش فيه الدي اتش اس. ده كان لازم فيه يتعمل بروكسيمال فيمورال نيلينج ويتعمل ريدكشن مظبوط، وكنا طبعا افويد الكوميونيكيشن. طبعا ده الوير اللي موجود دلوقتي ده زي قلته، بل بالعكس ده عامل كوميونيكيشن وفي انفكشن يا دكتور جمال؟
لا ما عندوش انفكشن فورشنتلي انف.
يبقى احنا ممكن ده يتشال خالص الكلام ده كله، واي ثينك ان احنا نعمل له اوستيوتومي فالجاس اوستيوتومي ويتعمل له بليد فيكسيشن.
يعني you don't think external fixation has a role in this such a patient?
انت بقى تقول.
Professor Essam.
First of all, I would like to congratulate you for the very difficult cases and innovative techniques. Now I got a problem of a young chap with ununited neck of femur, possibly AVN. We should strive to have his native hip. The only way in my way of thinking, I'm thinking all inside the box, not outside the box like you, is valgus osteotomy. I would like to use a DHS for valgus osteotomy. The pathway of the leg screw will be in the center of the head and neck this way, and I will do osteotomy here. The advantage of DHS in such case is that I avoid medialization of the femoral shaft. I will lateralize the femur to the DHS plate.
Yeah, Dr. Essam, Professor Essam, you said medialization of the femoral shaft. Exactly.
But by angled blade braid.
Yeah.
With DHS, you don't.
This is very important to correct the mechanical action.
Yeah.
Medialization.
We are no more using the double angled blade because it medializes the shaft, and this disturbs the mechanics of the head. So we usually use either 130 angled blade or DHS, and this is the solution of such case in my head.
This is a solution of internal fixation.
Yes, of course.
Professor Abdelsalam.
Yani, I support the opinion of Professor Alaa El Zoheiry, Professor Essam Sherif. I also do valgus osteotomy with fixation, the DHS 135 degrees placed in the center of the femoral head and neck, and then we remove a wedge and we convert the shear forces into compression forces.
عبد السلام، انا عملت كومنت على الدي اتش اس نفسه زي ما انت قلت في المحاضره بتاعتك.
تمام.
من الاول يعني عشان نستفيد ليه حصل كده.
هو صعب ان احنا نحكم على السيتويشن ده ابتدى ازاي الا اذا كان عندنا الايميديت بوست اوبرتيف اكس راي، ودي بيزل فراكشر اوف ذا نيك. يعني المفترض ان هو يعني لو اتعمل كويس ولو حصل بليسمنت اوف ذا سكرو كويس ربما ما كانش حصل
الفيلير. انا شايف يا عبد السلام الميديال كورتكس او الميديال باترس مش سليم، وده برضه له فاكتور كبير في الانستابيليتي في الحاله دي.
انا مع حضرتك، بس برضه انا عاوز اقول لحضرتك يعني ايه برضه من ده السيتويشن ده بقى له فتره، يعني ده has been there for some time، فده مش السيتويشن الاميديت، مش هقدر احكم عليك.
ايوه يا دكتور جمال اتفضل.
Vascular necrosis of the femoral head, does it affect the results؟
طبعا، لانه كمان ده زي ما انا قلت في التوب بتاعتي ان في الادلت ده لازم نحافظ على الفاسكولاريتي بتاعت الهيد عشان لو هنعمل اي عمليه بعد كده يعني نقدر نجيب نتائج لها.
تمام.
انا شايف برضو يعني الهيد مش مظبوط.
هو حضرتك الفاسكولار نكروزس اوف ذا فيمورال هيد ملوش علاقه باليونيون. يعني هو ممكن يحصل يونيون even if there is a vascular necrosis، وفي سن 22 years old you have to give all the chances possible of preservation of the femoral head. فانت حضرتك دلوقتي اللي همك انك تعمل اليونيون وبعدين بعد كده assess the femoral head. اذا كانت حصل فيها AVN we can deal.
نتعشى من ما يكونش حصل.
But it may pass يعني.
So Professor Abdelsalam, you think it's better to avoid the talk about arthroplasty in this young guy, okay?
يعني not immediately يعني it may be considered as a last resort.
22 سنة يا جمال لسه.
Okay.
As long as there is a hip joint and a joint space, a vascular necrosis does not contraindicate valgus osteotomy.
Okay.
Last, maybe I beg to differ. I'm not sure if there is a vascular necrosis or not.
Professor, as Professor Essam said, and that avascular necrosis is not a contraindication to do a valgus osteotomy or to promote.
لا بالعكس، ده ممكن تتصلح. ده ممكن تتصلح البايوميكانكس والفاسكولاريتي بعد الاوستيوتومي.
واضح طبعا ان انا اجينست الاغلبيه.
طول عمرك طول عمرك
كان معتاد.
بس انا شايف ان التيار عالي قوي.
out of the box.
التيار عالي قوي، فانا عملت internal fixation.
شفت بقى.
This is subtrochanteric osteotomy with medialization, submedialization, and the correction of the angle. This is the medialization, like Professor Essam said. It's very important to medialization. This is osteotomy rule number 2. If you cannot attack the deformity from the site of the deformity, this is the site of the deformity. The fracture is the site of the deformity. And you want to correct the mechanical axis, you have to do that displacement with your osteotomy. لو كنا صلحنا من مكان الفراكتشر ما كناش محتاجنا نعمل displacement. This is osteotomy rule number 1. We consider the fracture as an osteotomy. But the osteotomy rule number 2. As we do the osteotomy, are we going to correct the deformity from not? This is not the site of the deformity. We created another site. This is the osteotomy rule number 2. We have to do displacement to correct the mechanical axis. And you see this is the neck and the head. And now after we corrected the mechanical axis. And we had union, complete union.
يعني نعلن انضمامك لمجموعة الانترنال فيكسيشن.
ما انا بعد ما قلت if it's not your cup of tea, it's not your cup of tea. رجعت في كلامي تاني.
لا تمام، حلو قوي، جميل. يبقى نفس الايديا يا دكتور جمال برضه.
أفهم؟
نفس الايديا يعني.
نفس الايديا طبعا. It's the message here. We are talking about the principles. If you talk about external fixation or internal fixation, these are instruments. It's not the principle. The principle of correction of the deformities, the principle of the correction or reduction of the fractures depends upon many principles. They are not depending about the method of fixation. So whatever you do, you have to keep your principles. It's not, you have not to stick to one method of reduction.
صح. وكل عيان يختلف عن الثاني.
Yes, exactly. So you have to design your treatment according to the patient needs, according to the X-rays, not according to your training or where you come from. في عندنا أسئلة، نشوف أسئلة. في عندنا أسئلة يا جماعة.
هي إيه الشريحة دي يا دكتور جمال؟
Which one؟
اللي حضرتك استخدمتها في الحالتين اللي فاتوا.
دي مش proximal femoral plate. ثانية واحدة أقول شوية.
أيوه
دي بليت عادية، البروكسيمال فيمورال بليت القديمة. دي البروكسيمال فيمورال بليت برضه في الفالجاس اوستيوتومي.
هي اهم مسمار فيهم يا دكتور جمال اللي هو التحتاني خالص ده، هو ده اللي ايه يعني جاي ده مهم قوي قوي. حتى مع الجديد البليت الجديد هو ده برضه اهم.
دي اللي بتعمل لك الديسبيسمنت لوحدها. يمكن دكتور عصام
ايوه، هي اناتوميكال شيب.
ده شاف الديسبيسمنت حصل من غير ما انت تفكر، مجرد
ايوه اناتوميكال شيب ده يا دكتور جمال.
الاولانيه
بس انا رايي كنا نستخدم مثبت خارجي يا دكتور جمال.
ايوه. we answer the questions. دي حاله ثانيه برضو. ده فراكشر نيك فيمر، شاب جاي بعد سنتين من الفراكشر.
هو عنده كام سنه؟
كوكسافار على الناحيتين.
عنده كام سنه يا دكتور جمال؟
عنده 24. but this is viable. عمل MRI وعمل بون سكان viable بعد 2 years. The problem if you correct the deformity here هيبقى عندك مشكلة هنا برضه. وthis deformity is very difficult to correct.
بعد سنتين يا دكتور جمال.
بعد سنتين. المشكله ان هو عنده other deformities down. If you correct it, you have to manage other deformities below down.
وبعدين البروبلم برضه هنا زي ما حضرتك قلت اللي هو السوفت تيشو، احنا خايفين على النيورو فاسكولار. يعني لما نيجي نشد لتحت احنا خايفين بقى على النيورو فاسكولار برضه.
I have an experience with some of such cases. I do it stage. I have experience with some of such cases. This is mostly a congenital coxavara, ultimately ended up with fracture neck of femur due to the stress. I do correction stage. I do valgus osteotomy, and if I am satisfied and if it does unite, I choose between another valgus osteotomy or transfer of the greater trochanter, distalization of the greater trochanter. This will help in the mechanics of the hip. So you may do two valgus osteotomies successively separated by some time, maybe 1 year, or you may do one and then transfer of the greater trochanter distant. If it is unilateral, you have to do two because you will achieve length. But if it is bilateral, you may do one valgus osteotomy as much as you can. You will go with your implant this way, and then osteotomy here, and then valgusization, and then transfer of the greater trochanter distally. You have better advantage of the abductors. Mechanical advantage.
طبعا فكرة ممتازة Professor Essam, but the problem is that we have many secondary deformities, distally and femorally. I don't have the whole X-rays of these patients because I put it in the last moment. But if you want to correct anything fully, you are going to have a different problem. So if you want to correct this severe coxavara, you are going to have, and you have coxavalga, you are going to have severe valgus deformity of the knee. And this is a real problem. We will see the answer afterwards, but we have many questions and we have to answer them to interact with the people. Professor Alaa, question to Professor Alaa. Are there still a role for closed reduction and external fixation treatment of displaced femoral fracture?
معلش السؤال تاني يا دكتور جمال بعد اذنك عشان
هو مش عارف، هو بيعكسني انا، بيسالك if there is still a role for closed reduction and external fixation in treatment of displaced femoral fractures. المفروض يسالنا انا.
احنا اتفقنا انه كل عيان every patient have a special situation اللي تقدر تشتغل بيه وتجيب بيه نتيجه اعمله. زي ما الدكتور جمال كان لسه بيقول، يعني ما بنتكلمش الوسيله ايه، عاوز انترنال، عاوز في الاكسترنال، عاوز كومبايند، اي وسيله تعجبك اشتغل بيها تكون تعرف تعملها. انما كل عيان يختلف عن دكتور جمال ورانا السيتويشن ان احنا ممكن بنستخدم كلوز ريدكشن واكسترنال فيكسيشن. if you can do it تعمله.
سؤال للدكتور عبد السلام عيد. دكتور عبد السلام, in which X-ray film size or distance from the cassette beam I will measure the lateral wall and other measures to obtain actual measures, not apparent one.
طيب هو بس انا اسمح لي عاوز اضيف حاجه بخصوص موضوع الكلوزد ريدكشن للفيمورال نيك فراكشرز. هو طبعا في يعني most people use وسكسيد in closed reduction، وفي عندنا المانوفرز بتاعت الريدكشن الويتمان تكنيك والليد بيتر تكنيك. والاوبن ريدكشن is used if you cannot obtain good anatomical closed reduction according to Garden Alignment Index، علشان خاطر ما ينفعش تعمل النيك فيمور الا لما تكون properly reduced. نيجي للسؤال. السؤال دلوقتي كنا زمان واحنا نواب قبل ما يبقى في نيو اكس راي ماشينز والسي ار والحاجات الديجيتال، كنا بنعمل يعني المسافه بتبقى محدده بتاعه التيوب والكاسيت، وكنا بنعمل subtraction of 15% او حاجه زي كده علشان خاطر انك انت تقدر تحدد الماجنيفيكيشن، تشيل الماجنيفيكيشن وتقيس المسافات بتاعتك. دلوقتي في وجود النيو اكس راي ماشينز والديجيتاليزيشن والكلام ده، سهل جدا انك تطلب منه انه يعمل لك بقياس رسم، او يقول لك يقيس الانجلز. يعني انت قول له قيس في الحته الفلانيه، هو هيقيس لك وزود بقى ماجنيفيكيشن ولا كلام من.
سؤال ليا: what about the use of trochanteric fixator under local analgesia in physically unfit cases؟ هو الحقيقه السؤال بيعبر بالظبط عن معظم اللي انا قلته. مش مهم، لان انا شفت دلوقتي مثلا رساله مكتوب the method of Elizarov in treatment of trochanteric fractures. لما شفت الرساله لا علاقه الرساله بالإليزاروف خالص، هو بيحط 2 هاف بينز تحت و2 هاف بينز فوق، نفس اللي احنا بنقوله يعني. اللي بتكلم عنه the method of the reduction. وايه unfit patient؟ انا ما اعرفش unfit patient دي خالص، ما اعرفش. يعني شوف لي حد انستيزيا يتكلم على unfit patients.
هو مفيش كونتر انديكيشن فور انستيزيا دلوقتي يا دكتور.
ايوه مش حاجه اسمها كده. دكتور التخدير يعني ايه؟ بيبنك كل الحالات. بيبنكهم يعني ايه؟ لوكال انستيزيا ده جزء من البنج، سواء بيبنك بلوكال انستيزيا، سواء بيبنك ابيديورال، سواء كذا. انما حكايه انفيت فور ايه مش عارفين. وايه العين الانفيت ده؟ دي طبعا تعبير ما احناش عارفينه في الوقت الحالي. الاساس في الموضوع هو الكلوزد ريدكشن تكنيكس، مش اللي انا بحطه جوه. هو السؤال نفسه بيعبر عن ان المفهوم العادي. انا فاكر الاكسنال فيكسيتور ان في تروكانتريك فيكسيتور، وانا رحت ناقشت رساله: يا جماعه مش ده الموضوع خالص. مش موضوع ان انا عامل تروكانتريك فيكسيتور فبحط 2 هاف بينز فوق و2 هاف بينز تحت. This is not true at all. ده لا علاقه له بالموضوع، ملوش اي علاقه لا بالفلسفي بتاعت الاكسنال فيكسيتور ولا حاجه. الفلسفي كلها ازاي تعمل الريدكشن من غير ما تعمل اي انسجن من اي نوع.
لازم يا دكتور جمال المسج ان في اليانج ادلت، لازم المسج بتاعتنا النهارده في اليانج لازم اناتوميكال ده عشان ما يحصلش كومبليكيشنز بوست اوبراتيف.
The method is how you achieve the reduction. The method you achieve the reduction. This is very important. طبعا احنا تخطينا الوقت بتقريبا نص ساعه، احنا كان معانا لغايه 11 تخطينا نص ساعه.
يعني الحلقه دي
I think now we اتفضل دكتور علاء، اتفضل.
بقول يعني النهارده حلقه علميه دسمه جدا، ونرجو الناس تكون استفادت يعني بصراحه.
الحقيقه it was a great event that we have Professor Alaa El Zoheiry with us, Professor Essam Sherif, and Professor Abdelsalam Eid. Thank you so much for giving us your expertise in the field. It was very fruitful session. شكرا طبعا يا جماعه على السيشن الجميله جدا، ونشكر فيها اساتذتنا طبعا الاستاذ الدكتور عبدالسلام عيد، الاستاذ الدكتور عصام الشريف، والاستاذ الدكتور علاء الزهيري على المعلومات القيمه جدا وعلى الدسكشن الجميله الحقيقه اللي موجوده. وطبعا بوعدكم ان شاء الله كل يوم جمعه ان شاء الله الساعه 9 مساء في سيشن على ذا هيب ستيت اوف ذا ارت، احدث المعلومات اللي بتلاقيها في مجال جراحه العظام في مجال الهيب. وفاينلي I would like to thank Inspire Company. شكرا شركه Inspire على المجهود اللي عملتوه معانا عشان يطلع الويبينارز بهذا الشكل، وعلى الديمونستريشن على الابيكسابان والرول بتاعه في بروفيلاكتيك as a prophylactic anticoagulant against.
السلام عليكم.